And any questions from the audience? Can I ask you specifically about driveline management? Because that's one of the major Achilles heel in long-term support patients. Do you teach the patients to do dressing changes themselves, or do you have specific sort of nursing staff going in to dress wounds for patients?
So dressing is one of the most critical points in long-term support, especially in outpatients. We prefer to train the family to make the dressing, and for long-term support it gives the best results. When there is no family available, it makes a physician at home or nurses at home. We recommend to make the dressing 1 time a week when it's clean. In case of infection, it should be done every 2 days or daily. It's clear we should discuss around that when the patient has a device for more than 9 months, the risk to get an infection on the driveline is more than 90%. And that explains that a lot of patients get also antibiotics for a long, long time. So we need small driveline for minimize the rate of infection.
George.
Thorsten, you have shown us this picture of this 71-year-old man who received a total artificial heart. My question is, in times of severe donor shortage, which you presented in one of your slides as well, what is the age limit of implanting a total artificial heart in a patient like this? I mean, it's tricky. It's a tricky question. I know that. But, I mean, you probably, since you did it, I mean, probably not personally, but there should be an answer for this as well.
In case a patient asks us that he will gain some several years and he is in an intellectual situation to understand what will have with that, I think we cannot say, no, we will not do that. And I hope with a new generation of non-pulsatile devices we can use for biventricular support, like the hardware biventricular, maybe it's a good chance for long-term permanent support for this kind of patient.
You mentioned that patients are provided with some form of psychological or psychiatric assessment before discharging home, and we've seen also from your slide of course of death long-term, several patients committed suicide. Do patients get ongoing psychiatric or psychological support?
Yeah, we have a specialized psychological team in our center, and they take care of our patients who were transplanted and our patients on device. And they could observe that the most critical point starts when the patient is mobilized after device implantation, the first month after the operation. But additionally, we could see in 5 patients some suicide and long-term support.
Yeah. And what's the interval between outpatient follow-ups in the long-term supported patients?
Sorry?
What's the interval between repeated outpatient visits or clinic visits?
The interval. So the interval, it depends between weekly, when the patient is sent at home for the first time, and every 9 months. It depends totally on patient. When the patient is stable, there is no problem, no driveline infection, we can see again after 9 months. But we say every patient, in case you have any problems, call us immediately and you can come back every time when you need.
Are you using telemedicine or remote sort of
phone calls? They phone us, say I have a wound infection, they call us, I have arrhythmia, I have a feeling in the chest, abnormal, we say go to the doctor at home, or we say them came in the hospital immediately. But so we have so many outpatients at the moment that we don't see them weekly. We make a time interval of 9 months, and that works very well. But the patient should be a co-worker. He should work with us and phone us in case of problem.
You have shown that you are assessing quality of life of those patients. Can you provide us with some data regarding perception of quality of life in patients with destination therapy or patient on long-term support waiting for our transplant?
Yeah, I don't have data with me with quality of life, but I know we worked on that also with Dr. Komoda. We analyzed the quality of life, and we could see that the quality, we compared quality of life patients on device and transplanted patient. And we could see transplanted patient has much higher quality of life than patient on device. But we know also for permanent patient on permanent device, I asked the patient, your feeling now on device, is it better after the operation than before? And they say, yeah, it's better with device than before. They are more mobile, they can do more, and the quality of life is better. I don't have data with me here.
So this comes to this specific question because the idea is to see if you can pick up some differences in patients that are on destination therapy, on patients that are on a VAD for a long time waiting for transplant.
Maybe there are some differences. I don't have data with me, but all patients in our center know they wait for several years for heart transplantation. And after the implantation, when we sent at home, they are not on waiting list. When they came back in our outpatient ambulance, in this moment we ask them, what's happened with your future? Would you like to be transplanted later? In case they say yes, we make right heart catheterization, computer tomography from the chest, and they are put on waiting list, but the waiting time is 2-3 years at the moment. The only chance to be transplanted in Germany is to put them on urgent or high urgent list and to let stay them in hospital. And to say the patient urgent listing, staying in hospital means staying 9 months in hospital. No patient will do that.
So you're managing the patient's expectations to try and...
It's the most patient is...
Yeah.
It's permanent.
There was one question from the audience. Lady in the middle, yeah.
Yes, I had a question. I'm not really sure how you're...
Excuse me, can you state your name and institution, please?
I'm Rosemel from Melbourne, Australia. I just wondered how your primary care physicians are involved in the care of patients when they go home in terms of psychological support, maybe drug management, that sort of thing.
So, for the beginning of the program, for the first 200 patients sending at home, the patients were accompanied by a nurse of our team, and the doctor was trained on this kind of patient. The physician at home was trained on the kind of patient. But at the moment we don't do that. This is too many patients. We make a phone call to the doctors, we explain it, and we work with him together. When the patient goes to the physician at home, he call us and he asks what should we do, what should be changed. But for that we have a 24 phone call, and it works well.
Okay, thank you very much. We'll move on to the next presentation.